Hi all and welcome. My name is Courtney Diamond and I am currently a graduate student in the Department of Biomedical Informatics at Columbia University. But at the time of completing the work that I'll be sharing today, I was an affiliate of the Division of General Internal Medicine at the Massachusetts General Hospital in Boston, Massachusetts. It's my pleasure to present to you the results of our efforts to use natural language processing to identify abnormal breast, lung, and cervical cancer screening test results from unstructured reports to support timely follow-up. I have no financial or other disclosures to make. Cancer is the second leading cause of death in the United States, with 241,000 deaths attributable to breast, cervical, colorectal, and lung cancers alone in 2020. There exist many efforts to bring patients in for their initial cancer screening tests with, generally speaking, good success. Roughly 80% of the age-appropriate population completes their screening. While screening for cancer can reduce mortality, this can only occur with the timely and appropriate follow-up of abnormal cancer screening test results. While rates of initial screenings are high, the rates of follow-up to abnormal results are modest and vary widely, as you can see here. Higher severity findings tend to have greater follow-up rates than a lower severity finding. These rates not only vary across severity of finding and cancer type, but also clinic settings and patient demographics. This suggests the need for a more holistic approach to facilitate follow-up, addressed at the primary care level. This motivates our study, MFocus, or multi-level follow-up of cancer screening. Our ultimate aim is to improve the follow-up rates to abnormal findings of breast, cervical, colorectal, and lung cancer screening tests that are overdue for follow-up. We've designed a stepped-level approach that incorporates both technologic interventions and population management interventions, creating a comprehensive system for tracking patients with abnormal test results and their follow-up. As our focus is on tests that are overdue for follow-up, MFocus is a fail-safe meant to supplement existing care processes. A few brief words on the design of the MFocus study. We've implemented a 4-arm randomized controlled trial across 2 primary care networks in the Northeast United States, including the Mass General Brigham and Dartmouth-Hitchcock Health networks. In total, we have 40 primary care practices involved in the study. All patients in these practices who have had a qualifying cancer screening test enter our tracking system, where we determine if they've had a qualifying abnormal result and, if relevant, sufficient follow-up as determined by nationally implemented guidelines. Ultimately, we are tracking the completion of appropriate follow-up within 120 days of a patient becoming eligible for MFocus. A little more about the intervention. As you can see, we have implemented a stepped care approach with patients in Arm 1 receiving the standard of care. All patients in Arms 2 through 4 receive the technologic component of our intervention, which involves automatic updates to the patient's electronic health record. At the Mass General Brigham, or MGB network, where the Epic EHR is used, we utilize the health maintenance and problem list functions to add descriptions of the abnormal result to the patient's chart. You can see here an example of a health maintenance modifier that we've created for MFocus. For study tracking purposes, we use these modifiers to create reports in the EHR for study staff to track and manage population health management functions. And here is a sample of a problem list addition, this one for a test patient who's had a qualifying LRAD3 result. Now, as I alluded to, we also carry out population management functions in Arms 3 and 4. These include using those internal Epic reports to facilitate patient outreach, which includes letters, MyChart messages, and phone calls. And the final component of the MFocus intervention is patient navigation, which is only done in Arm 4. This is intended to provide continued outreach to patients and assist in the mitigation of patient-level barriers to follow-up that are associated with social determinants of health. Now, returning to an earlier point, the entirety of the MFocus study is predicated upon knowing that a patient is overdue for follow-up of an abnormal result for one of the qualifying cancer screening tests. So fundamentally, we must be able to identify these 3 elements from the patient chart. Firstly, the qualifying screening test, which is easily done through queries of groups of relevant procedure codes. The second component is to identify the result of the test and, by extension, determining if it's abnormal. And finally, we must ascertain if a patient has had appropriate follow-up for their test result. Within the MGB network, we must use NLP to extract test results, as our breast, cervical, and lung cancer screening test results are not entered into structured fields. Additionally, in some cases, NLP must be used for identification of follow-up procedures in those scenarios when broad procedure codes are used, such as anatomic pathology. This is particularly the case when trying to identify specific gynecological follow-up procedures for our eligible cervical cancer patients. Thus, we were prompted to develop in total 4 NLP pipelines, one for each of the breast, cervical, and lung cancer screening tests, and another for parsing the text of anatomic pathology reports to identify potential gynecological follow-up procedures. To provide a sense of how these are integrated within our system, we gather our data from the Epic EHR, which is ultimately loaded into the Enterprise Data Warehouse, our main operational data repository that is updated nightly. In addition, we've built our own mFocus database, which we rely upon for our study-specific operations. This includes storing the raw free text reports of the cancer screening test results, which are then parsed by our NLP programs. The codified outputs of the NLP are saved to our database and can then be used to make eligibility determinations and facilitate the addition of relevant health maintenance and problem list terms. With respect to our cohorts, all patients affiliated with an MGB primary care practice were included in our queries for qualifying breast, lung, and cervical cancer screening tests. When searching for relevant cervical cancer screening follow-up procedures, we only queried the anatomic pathology procedures for those patients who were currently enrolled in mFocus for a qualifying cervical cancer screening test result. Moving to the technical details, our NLP pipelines were developed as part of the MTERMS, or Medical Text Extraction, Reasoning, and Mapping System NLP suite, courtesy of our collaborators at the Brigham and Women's Hospital. We use a knowledge-based approach for several reasons. The information extracted is specific. Each of the cancer screening test result reports use their own well-defined lexicons. And finally, this approach enables negation detection through pattern matching. The underlying process involves 3 components. Firstly, pre-processing of the text reports to clean the text, including removing white space and non-alphanumeric characters. Secondly, pattern matching, in which relevant phrases and words are identified in the report text. And finally, assignment of extracted phrases to standard values as defined in our knowledge base. The development of our lexicons was an iterative process. For each report type to be analyzed, we randomly selected 500 reports and manually annotated relevant results. The interim versions of the lexicons were integrated into the program, and results were assessed for precision and recall. This process was repeated for several iterations until suitable performance measures were achieved, indicating saturation. The mFocus system, including breast and lung NLP pipelines, was launched in August 2020, with the cervical NLP pipeline following in October. For each report type, we determined an earliest permissible date to accept in the system, based upon guideline-recommended follow-up intervals. For each pipeline, quality assurance was performed and a sample of outputs were reviewed by study clinicians. We oversampled less common but more serious results, for example, a BI-RADS-5, to ensure accuracy of detecting more severe findings. Once we confirmed the successful integration of the NLP pipelines, we began our daily query to identify new cancer screening tests from the date 2 months prior to the date of the query. This 2-month lag allows for standard outreach procedures and follow-up to occur unimpeded, as mFocus is not meant to replace these standard care processes. This lag still allows us to identify abnormal test results well in advance of their becoming overdue. As of May 2021, we have processed over 380,000 cancer screening test result reports using our NLP pipelines in order to identify those patients with qualifying abnormal results. Mammograms and pap smears are our highest volume tests, given that LDCT chest scans are only recommended for a smaller population of patients who have a known history of smoking. Additionally, over 2,800 anatomic pathology reports have been processed to identify whether those patients currently eligible for a cervical abnormality had appropriate gynecological follow-up. As you can see here, we demonstrate high levels of precision and recall for each of our pipelines. The cervical NLP pipeline has 4 classes of output, given the different concepts detailed in those reports. These include primary cytological findings, supplementary cytological findings, the HPV test result, that is positive or negative, and finally, the HPV genotype pool tested. Lastly, we report performance measures for the anatomic pathology pipeline's ability to identify colposcopies, a commonly recommended gynecological follow-up procedure. In addition to these performance metrics, we are able to report on the real-world impact of our system. As part of the MFocus workflow, study clinicians regularly review high-level abnormal overdue results to ensure appropriateness of fit for the study. Of 713 high-risk cervical abnormalities reviewed, our clinicians identified 15 cases in which patients were misinformed of their results. Most often was the case where a confusing free text report layout obscured a high-risk HPV test result, and the provider was entirely unaware of the finding until we notified them. This serves to highlight the real-world value of an automated text extraction system beyond the scope of identifying patients eligible for a clinical study. Analysis of our system has shown that the most common source of error is simply not having a result entered into the correct field in our EHR and data warehouse. This occurs when procedures are performed outside of the MGB network, or when external laboratories are used for testing, as these results are often saved as file attachments rather than entered into the EHR directly. Another common issue is variation in clinician annotation, most often associated with transcription errors in free text reports. The use of automated text extraction has been of great benefit to the MFocus system. Primarily, it serves as the only mechanism by which we can identify abnormal results, given that we do not have structured fields to report BI-RADS, LRADS, or Pap smear results. It has provided a reliable way to identify patients who may be eligible for our intervention without needing to manually review charts. In addition, our system poses the opportunity to compare the automated text extraction technique to the use of several semi-structured fields. In the MGB system, our colorectal cancer screening results are captured in 4 different locations in the EHR, one of them being the health maintenance module. This is the measure we determined would be most suitable to identify eligible patients for MFocus. However, we found that upon review of a sample selected as eligible using just the health maintenance modifier alone, 61 of 735 patients were not in fact eligible and had the incorrect health maintenance modifier applied to their chart. This is due to the nature of the modifier. It is not automatically updated or integrated to reflect the data from other sources, namely the procedure narratives and pathology results. Thus, we believe a system that automatically parses text from these other sources that could update modifiers appropriately would have greatly improved the accuracy of our cohort identification. There are, of course, limits to our approach, chiefly due to the nature of knowledge-based systems. This includes the requirement of domain experts' knowledge to create rules, the manual curation and maintenance of the knowledge base, increased complexity as rules accumulate, and finally, the fact that we can only identify those patterns that already exist in our knowledge base. Additionally, our system requires dependence on an external NLP pipeline that is not housed within the EHR and requires additional steps for implementation. Finally, our NLP pipelines were developed using data from the MGB network, and as such, patterns in the knowledge base are specific to our use case. Other networks hoping to adopt would need to tailor the lexicons to their own systems. In sum, we have demonstrated the high precision and recall for 3 rule-based NLP pipelines that identify abnormal results for breast, lung, and cervical cancer screening tests that are overdue for follow-up. We've shown the utility of an NLP pipeline in identifying relevant gynecological follow-up procedures from free text pathology reports. We've reported the pragmatic value of these pipelines in identifying patients misinformed of their high-risk test results. And finally, we discussed the advantage of using a rule-based NLP over a series of semi-structured but poorly integrated data sources. Thank you all for watching. I'd like to acknowledge the MFocus study is funded by the National Cancer Institute at the NIH, part of the U.S. Department of Health and Human Services. And finally, a big thank you to all our collaborators within the Mass General Brigham Network, as well as the Dartmouth Hitchcock Health Network. Thank you all so much. Take care.